Life, love, parenting. 3 words that connect so many of us, and ones that leave so many questions. Let's share your problems. Let's share your ideas. Let's talk. Here are your hosts, Bianca and Philip.
Thanks for joining us. I'm Bianca Tyler with my husband, Philip.
Hello, everybody.
And you're listening to Let's Talk with Bianca and Philip, brought to you by our title sponsor, the 40dayreset.com weight loss program. This show is about life, love, and parenting.
And today, Dr. Bob Berookhim, Assistant Professor of Urology at Lenox Hill Hospital in New York, joins us to talk about the treatment options to help prostate cancer patients, about nerve sparing and what it means for quality of life after surgery, robotics, and so much more. There are over 200,000 men diagnosed with prostate cancer every year. Dr. Berookhim specializes in the management of the after effects of prostate cancer treatment, particularly with regard to urinary and sexual function.
And be sure to friend me on Facebook under Bianca Tyler Mom Radio, where there's a link to both my TV site and the Let's Talk Mom site, where all of the shows are archived. So if you miss one or you want to look up a specific topic, just go to the letstalkmom.com and click on the radio show flower tab in the navigation bar. Dr. Berookhim, it is a pleasure to have you on air. This is
more than you know.
Yes, a mighty important topic. And it, we have learned, has affected over 200,000 men per year. And that's just in the United States. We're not even thinking about the whole world. We've learned that it's the second leading cause of cancer death in men, 30,000 men a year. Tell us a little bit about how the treatments for prostate cancer have changed over the last 30 years.
Sure, and I wanted to just start by thanking you for this wonderful opportunity. I'm a big fan of the show and really wanted to commend both you and Philip for the work that you do on your blog in terms of bringing visibility to this disease state and helping other people who are dealing with this sort of gain some information and see what other patients are dealing with
Thank you.
in this disease. So, as to your question of how treatment has changed in the past 30 years, there's been some pretty significant changes that have come along. And I think that the primary reason for that has been the advent of blood testing to help us identify prostate cancers at an earlier stage, which is the so-called PSA test. Mm-hmm. So initially, if we look back in the early to mid-1980s, patients who were being diagnosed with prostate cancer generally had an advanced disease where they were metastatic, and really the prognosis was dismal. And what has happened over time is we've sort of stage shifted to patients with earlier stage disease who are being diagnosed at a curable stage. With that stage diagnosis, there have been a number of refinements in terms of our treatment options. Starting first with surgery, we've looked at sort of how to spare the nerves that go to the penis that provide the impulse for sexual function. We've learned better how to improve male urinary continence after surgery. We've had technological innovations such as the advent of the robot, which has significantly decreased our blood loss, our length of stay, and the pain that the patients have. In addition, there have been significant changes in the use of radiation therapy, which frequently leads to equivalent cure rates. We're seeing lesser side effects and improved quality of life after that, as well as the advent of some newer technologies, such as cryotherapy, which is used to freeze the prostate, something called HIFU, which is high-intensity focused ultrasound. All of these are being used more and more in the localized prostate cancer patient at this point.
I wanted to ask you about the stages. We've just found out that Philip has prostate cancer, so we've been doing a lot of learning in these last 3 weeks.
Sure.
So we've learned that really this cancer isn't categorized by stages.
We're being told there is either low, medium, and aggressive, and other cancers get graded in stages.
Why is that?
Has that changed somewhat?
I think that the primary thing that we're finding is that staging in and of itself is less relevant in terms of your overall outcome, and that the picture of prostate cancer takes into account a few different variables. One is what's called your Gleason score, which is a pathologic finding. It's a finding that they find under the microscope after a biopsy, which looks at how the glands within your prostate are actually, what their architecture looks like. One is based on your PSA level, which is that blood test that we spoke about. And then the last is based on either physical exam characteristics or how much of the prostate is involved either on exam or when the prostate is removed. And so when we take the sum of these three issues, so one being stage, one being Gleason grade, and one being the blood test, we're able to give you better prognostic information, better able to predict, what your likelihood is of cure and what the likelihoods are of recurrences in the future.
Mm-hmm.
Now, that Gleason score goes from 1 to 10, but the Gleason score is given out as a 3 plus 3 or a 4 plus 5. What do those two differentiators mean?
So what essentially we look at with the Gleason score is the first letter. So if you look at it as a Gleason A plus B, the Gleason A is referring to what the most common architecture is being seen, and the Gleason B is the second most common. And what we've seen is that Gleason 3 cancers behave differently than Gleason 4 cancers and behave differently than the Gleason 5 cancers. Now,
right, so if somebody's got a 3 plus a 3, it's not as bad as a 4 plus a 5.
Exactly right. And ultimately what has ended up happening with our stage shift is that we don't diagnose Gleason's 1 and Gleason's 2 any longer. So if you're going to diagnose a cancer, the lowest risk cancer that one can have is a Gleason 3 plus 3.
Oh. Did you
so
know
it really, the score goes from a 6 to a 10. It doesn't really start at a 1 any longer.
Oh, okay.
Right, so if you're on a 2 plus 2, it's kind of, okay, we'll monitor you.
It doesn't, we don't even see that diagnosis any longer. It comes up as a benign finding.
Ah.
So if somebody has like a 4 plus 5, then that would be someone who's already too far gone for proton radiation or just radiation or that high-low, what were you calling it, a high-low?
HIFU.
HIFU. Yeah. So they really should just skip to a surgery?
Not necessarily. I think that, when we look at Gleason score greater than 8, what we're saying is that those tend to be our most aggressive subgroup of prostate cancers. And in that group, depending on a few different variables that we look at, including how much of your biopsy is associated with cancer, what we have to decide is how aggressively we want to treat.
Mm-hmm.
And in some patients, in some situations, one treatment modality alone will not be enough.
Right.
So in that situation, we may be thinking about doing surgery plus radiation plus hormones. Now, there's a role for surgery even in lower-risk prostate cancer patients. So everything sort of depends on the patient and their presentation, and I think we'll get into that a little bit further as we discuss over the course of our discussion today.
I wanted to ask you about laparoscopic surgery.
When we talk strictly about laparoscopic surgery, we're talking about the use of long chopstick-like instruments that are inserted into the abdomen through small incisions that are driven by the surgeon who is standing at the bedside. With the robot, you are attaching those chopstick-like instruments to a robot, and then you are operating the robot from a distance across the room. And the difference with the robot is that because of the use of the machine, you have different degrees of articulation in the instrumentation itself, and it helps you to get into smaller spaces where you can better identify what structure you're cutting and can help in terms of your visualization and really getting a more precise and accurate surgery performed.
And that would also help with the nerve sparing, right?
It can.
It can.
Nerve sparing is very much surgeon dependent. So you can have a terrible surgeon who sits at the robot, they're likely to resect your nerves.
Mm-hmm.
But if you take an excellent surgeon who knows how to find those nerves, then the robot is just an instrument that surgeon is using. So the robot in and of itself isn't really what helps to identify those nerves. It's much more surgeon dependent. When we talk about the nerves, essentially what we're discussing are the nerves that go around the prostate and then send a message to the penis that innervate it in order to respond to a sexual stimulus. And ultimately what we're looking for in prostatectomy in an appropriately selected patient is to try to spare those nerves as best as we can. Now, there are a few different factors that we look at in terms of nerve sparing and whether or not a patient is even a candidate. And ultimately, you have to remember that the primary reason for treatment is cancer cure. So if there is any involvement of those nerves with tumor, a smart surgeon is going to resect those nerves for the sake of the patient's survival.
Right.
Once you get beyond that point, and once you have a patient who is a good candidate for nerve sparing, essentially what you're looking for is a surgeon with good experience who has a proven track record and has done many of these before and has proven that in their hands, when they say nerve sparing, the nerve sparing actually does occur.
Mm-hmm.
So do they find out about the ability to spare the nerves once they're inside, or do they find that out prior to surgery with an MRI?
Usually, we get a lot of information from that MRI, and it can help us in terms of predicting what the likelihood is of nerve sparing. However, there are some patients where the MRI looks pretty good, and you get in and it looks like the nerve is involved with cancer. But for the most part, the MRI can definitely help us in terms of our preoperative planning.
So again, that's back to the quality of the surgeon for the nerve sparing and that decision to say, okay, there's a tumor on that nerve, it has to go.
Correct. And I think that some of the things that we tend to see is that less experienced surgeons may not even be able to identify the nerve.
Oh.
And there have been some studies that have looked at surgeons who do a high volume of surgery, but they do a bad surgery every time.
Mm.
So really that the experience and their outcomes really matter.
How do you find out the outcome of surgeons? Like, how do you know that...
If someone's got 25 years experience, but he's
they
got
could have
25 years of people survive, but the quality of life was not...
Like, how do you know that they were successful at nerve sparing?
It's difficult. Unfortunately, it's one of these things that tends not to be published.
Mm-hmm.
And to be honest, most surgeons who are not getting the best outcome are not going to be trumpeting that bad outcome.
Right.
So I think what you really need is people who you trust in terms of referring doctors. And if you go to centers of excellence, so here in the New York area, there's 4 or 5 major centers with world-renowned surgeons. Any one of them is likely to be able to do your nerve sparing, and it's because their reputation speaks for themselves.
Right.
These people have established themselves, and it's a reason why they've been established.
Mm-hmm.
Now, talking to those doctors about the different forms of treatment and then the outcomes, etc., I've had some surgeons say that incontinence and loss of sexual function, you'll be 2 or 3, maybe 5 months, depending on the way you heal. And then another doctor said, minimum of 3 years. So
yeah,
that's a wide gap.
Huge.
2 or 3 months to 3 years.
And then the one that said 3 years also said, and then only 50% of the men ever, come around again. So I'm like, oh my God, cross him off. He's off the list.
Yeah, I wouldn't
why
be
is
so
it so
fast to cross
wide?
them off.
Oh.
Because some of this is an honesty in reporting issue. We do tend to see some surgeons who over-exaggerate some of their benefits. So that's one part of this. There's another part of this, which is how do you define a recovery? And so does a continent person mean that he wears a pad but he only has a couple of drops here and there? Or does it mean that he never drips?
Mm-hmm.
Or does it mean that the guy who we're saying is now potent and no longer has erectile dysfunction is able to respond the way he did before surgery? Or are we saying now he's taking a pill and he's just able to get by in the bedroom?
Right.
Right.
It's hard
So
to tell.
The question of definition is an important one.
I keep hearing that there's going to be a new normal after surgery with impotence or erectile dysfunction or a functioning situation, but it's not the way it used to be. Is this your experience? This is what we're going to be seeing?
I think so. I mean, I think that across the board, what we do see is that there will be a decline in terms of that man's sexual function. Now, there are certain patients who, at the end of a year to 2 years, get back to their baseline. It's probably, depending on your patient selection, can be somewhere between 25% to 50%, where they're completely back to where they were before surgery.
Mm-hmm.
For the rest of the patient population...
Wait a minute, can you say that again? I needed to hear that again.
Yeah, so I think if you look at recovery being back to baseline, so if you look at that man a week before his surgery and what his erectile quality was in the bedroom,
Uh-huh.
and you say that at 2 years you're going to have that same erectile quality without any use of medicine, depending on your patient population, it's 25 to 50% who can get there.
That's high.
That's good odds.
That's pretty
but
good.
So that depends on your patient population, though. So, in that patient population, generally what we're talking about are men who have excellent erectile function at baseline. They're men who tend to be young, so 50 or younger.
Okay.
And they're men who have excellent surgeons with an excellent nerve sparing.
Right.
If you look at the overall population, the data looks more like it's about 15% will get back to baseline. And that's back to baseline still with excellent nerve sparing and an excellent surgeon.
Does that seem to be the direction that most surgeons are going in now, is the nerve sparing?
Nerve sparing should be offered by anybody who's doing this operation, I think.
Well, offered, but I mean, is it really what you're seeing? Because you're in the field, you see this all the time. Is this really the focus? Because I mean, this one surgeon that we talked to, it was not his focus.
So it's the holy grail in terms of the localized cancer. Mm-hmm. I think when we look at more aggressive tumors, so if you look at the Gleason 4+5 that we're talking about, and in somebody who likely needs more than one treatment option, a good surgeon is going to tell you they're going to resect that nerve, because what you want is to maximally remove all the cancer that's in the area.
Are the nerves the same as the glands when we're talking about surrounding the prostate?
No, so it's two different things that we're talking about. So the prostate itself is a gland, and when we remove the prostate, we also remove two small structures that sit behind the prostate called the seminal vesicle. Mm-hmm. So most likely what they're referring to is removing the prostate gland along with the seminal vesicles themselves.
Oh, okay, because I was wondering where the glands fit in there. So with that in mind and along that vein, is it different when a man orgasms at this point? Because if you remove that gland, there's nothing there. There's nothing to travel along.
Well, the prostate gland, for those that don't know, holds the semen. So once you remove that, there's no semen to carry the sperm. Is that correct?
But a man can still orgasm. Is that correct? Because we're reading a lot of stuff on the Internet, and I don't know what's right and what's not.
So you're right. I think that the best way to think about this, though, is that an orgasm is an event that occurs between the ears, and an ejaculation is an event that occurs between the legs.
That's a great way of putting it.
I love that. Perfect.
So the orgasm is a brain event. That is something that, as long as your sensory nerves are still intact, a man will still get the sensation of that climax.
Great. I was reading somewhere that sometimes it can be even more intense.
Some people will say that. And we definitely have some patients who do report that. There are some patients who they pay a lot of attention to the ejaculate itself, to the semen coming out, and for those patients, it's a significant difference. But I think as long as somebody knows that that's coming, most people, it's just one of those things that they say, okay, now I no longer have any semen, but so be it. I still get that sensation of climax. It's still a satisfying experience.
Excellent. Okay. And we also heard that Viagra won't necessarily work because of, I don't know, what is it, nitric oxide?
Well, interesting. One doctor said Viagra does not work, and then another doctor said, post-surgery, there's things like Viagra. So I thought, well, hang on.
That's confusing. Well,
there's two different things here. I think that one part of this is that in order for Viagra to work, it requires the nerves to send the message along to the penis. So if those nerves are resected, meaning if they're cut out and there's no nerve to send that impulse along, then I could hit you with mega doses of Viagra and never get you anywhere. Now, if the nerves are still intact, there is a role for Viagra, and so a lot of it really depends on what that patient's nerve sparing is, whether or not this will work. That is not to say we don't have treatment options. So even when Viagra fails, there are a number of things that we can do.
Like what?
So one of the options that we look at, and a lot of men sort of hem and haw around this, is something called injection therapy, where essentially what we do is we take a very small needle, and I'm going to reiterate, very small, and you inject the medication directly into the penis. That is injected 10 to 15 minutes before activity, and because it's bypassing the nerve, a lot of men are able to respond with a robust response with that injection alone, whether or not they have nerves in place.
Okay, that was my next question. If nerves cannot be spared and they're taken out or resected, is a man able to have an orgasm? And now you're saying that the first step is that shot, the needle, and then it's all in the mind. Is that right?
So it is, and I think that all of us tend to equate erection with orgasm, but the two don't necessarily need to be together. So even if a man can't achieve an erection, he can still achieve an orgasm.
Okay.
But, for the sake of sexual activity, in order to achieve
partner, right.
with a partner, in order to achieve that erection, either we can go with injections, or in some patients, and we actually do this with some frequency, we can put an implantable device directly into the penis, which sort of restores their spontaneity.
Is that like the pump?
That's a pump.
Okay.
And sort of the way that the pump works is that we place a pump inside. All of it is internal. There's nothing on the outside of the body.
Okay.
And when the time is right, the man inflates. He pumps it up almost like the basketball sneakers that used to be out like 20, 25 years ago.
I can picture that. Okay.
This brings a whole new conversation to deflate gate, doesn't it?
Exactly right. That's the only thing I thought about when they said deflate gate. So.
I bet. Oh my God.
With all the different forms of treatment, there's surgery, there's seed therapy, there's cryogenics you've mentioned, there's this proton beam radiation. And I found when we started this journey, which was only a few weeks ago, that I went into it feeling that, well, if I go and see a guy who specializes in seed radiation, he's going to recommend seed radiation because that's his specialty field and that's what he believes is going to be best for me because that's the... And then the surgeon does surgery and the cryogenics person says cryogenics. How does the person who's lost in the woods decide what's the best option for me? Because seed man's going to say seed and surgery man's going to say surgery. How do you get that choice correct?
You're absolutely right, and I think it's the biggest problem that all of our patients have. I think that sort of the best way around it is always to seek a second opinion. That regardless of what the reputation is of the person who you are seeing, it is worthwhile to do your own homework and to go see people who specialize in each different field. And it sounds like, in terms of reading about your experience, that eventually you came across people who gave you an unbiased opinion.
Yes, I was very surprised when I sat down with the proton beam specialist at Memorial Sloan Kettering, and fully expected him to say proton beam is the way forward. And from what I read, that was what I wanted to do for the minimal side effects. And he said, looking at everything I have, with all the evidence we have on you, with your bone scans and your MRIs
numbers.
and everything, your numbers, your Gleasons, without a doubt, you need surgery. Then you need radiation. Then you need HRT.
Correct.
And it kind of threw me that he was saying, no,
we were shocked.
Don't come to me, go to the other guy.
Well, he was saying go to the other guy first.
Right, to go there first. Good point.
Yeah, I mean, and you yourself have now seen the value of that, getting multiple opinions.
Yes.
I think, it can be difficult to find people who you can trust, but once you find them, and once you've identified sort of what treatment course you want to go down, then you can once again go back to the selection of who's going to do this part, who's going to do that part.
Do all men have to go through the hormone replacement treatments and therapy?
No. So the first part of this is that it's not hormone replacement is something that we do for women who are postmenopausal. So actually what we're doing is hormone withdrawal. This is called androgen deprivation.
Oh, it's hormone withdrawal. Okay.
Yeah, so it's a form of chemical castration.
Oh, right. Okay, yes, I did hear about that. So that lowers the testosterone levels for like a year or so?
I used to like you.
And then...
You're no less of a man. You just have a lower testosterone level.
So it lowers it for about a year, but once you're off of that, then it comes right back again?
Not necessarily right back.
But it'll come back again?
Usually it does.
Oh, okay.
Not in everybody. But for most people, after the course of a year to a year and a half, after stopping the medicine, most people will get back to where their baseline was.
But most men after surgery have to do that?
No.
Oh, good. Oh, okay. Oh, that's good news, too.
Today we've been speaking with Dr. Bob Berookhim about prostate cancer and treatments. Bob, is there anything you would like to wrap up with?
Yeah, I think that the main message that I want to get across is that there's a lot of fear and misunderstanding about prostate cancer, and that if a patient goes out and does their homework, frequently they can understand that this tends to be a curable disease, that there are a number of different options, all of which can be useful for different patient populations, and that there are side effects that these patients do experience. And that the important thing is that frequently when you're talking to your treating physician, they may overlook some of these side effects of treatment. Don't let that get to you. Ultimately, there are treatment options that are available, whether it is for urinary incontinence or for male sexual dysfunction. There are physicians out there who do specialize in this and can treat it and can help you get back to a more normal state. That really is the main message that I want to get across to your listener base.
All we keep hearing about in these last 3 weeks is that prostate cancer moves very slowly. So really, people do have time to do that research, because we found out on a Tuesday, we were at Sloan Kettering at 3:15 on Wednesday.
Yeah.
And the surgeon asked us, he said, well, when did you find out? We said, yesterday. It wasn't even 24 hours.
All he had was the biopsy to go off.
Yeah, and we were ready to do research and flipping out and like all the emotions. So all we keep hearing is it moves very slowly. You have some time to
You absolutely do.
Okay.
It's not something that you have to run that day, and I'm quite impressed that you were able to get in that day. So it sounds like you got some good connections. But taking your time to make the right decision is definitely what needs to be done in this disease state.
Mm-hmm. Yeah, I would think so, because we didn't realize there were so many different options. But then when we went back to another hospital and they said, you know what, you're not in the low or medium risk, you are in the aggressive stage, and you are going to need surgery. So at this point, it's really just looking for the right surgeon.
Which we're still doing, even though they've booked a date about a month out. Right. Then we're still going to see a different doctor at a different hospital for a third opinion.
Right.
And I think it's the right thing to do. I mean, nothing is. Once you're done, once your surgery is finished, you can't turn it around.
Exactly.
So, take your time, figure out what you need to do.
100% right, what you just said, because you cannot change what has been changed. So exactly. Thank you so much for joining us, Dr. Berookhim. It's been a pleasure having you on air with us.
The pleasure's been mine. Thank you so much for having me.
Thanks.
Thank you.
Join us next time on Let's Talk with Bianca and Philip on 1490 WGCH, brought to you by our title sponsor, the 40dayreset.com weight loss program. Lose 20 to 40 pounds in only 40 days, and it is guaranteed. Call 844-40-RESET, 844-40-RESET. Use the promo code Let's Talk for a free consultation and scan. And be sure to see their ad in Greenwich Magazine or visit them at www.40dayreset.com. Do it for yourself today.
And be sure to visit us and all our great sponsors on the website, theletstalkmom.com, all week long, and send your comments to Bianca at theletstalkmom.com.
Looking forward to hearing from you, and let's talk.
And we'll see you next week.